Good day. Today we will be talking about hepatitis B. This lecture will be a long one and will not contain information that is only high yield. This lecture is made for people who would like to deeply understand hepatitis C, deepen their knowledge, and get practical knowledge on the diagnostic, serology, virology, and treatment of hepatitis B. In this video, and be able to later apply this information. This is not a lecture to prepare for a test, but it is to prepare us for our patients. First of all, we will be using a mind map. This mind map is made using the application Xmind, and it looks kind of like this, where each branch is a specific part that we need to study and understand. And it all gets into one big picture. And we will be examining each branch alone. And at the end, we will make a small review of everything. If you want to skip to a specific section of this branch, you can click on we go back into full zoom and we can start. First of all, we will start by the virology of hepatitis B. We will use picture of the virus itself, which will help us. The virus is a double-stranded DNA virus. It is a Hep family virus. It's easy to remember because it's hepatitis DNA virus. It's a hepatitis virus that contains DNA, which is Hep. The first layer that we will be examining is the DNA layer. It is made from partially double strand and a small single strand part of DNA. Then we will have the capsid. The capsid is made from a core antigen. It's made from small subunits. Each subunit is a core antigen subunit, which we will call HBC antigen. This is important for later in the and in staging and classification of the disease. The next stage or the next layer is the layer between the capsid and the envelope. In this area, we will find the E antigen, which will be written as HBE antigen. And finally, we will have the envelope. On the envelope, we will have the surface antigen made from multiple proteins, which are all under the name of HBS antigen. This is the viral structure of our virus, and other than these big proteins, we can have enzymes. These enzymes have specific roles inside the viral life cycle. So here we start. The virus infects hepatocytes, and for it to get inside hepatocytes, first of all, it gets through the blood on a parental way. We will go in through this later a little bit. But first of all, it should go within a sodium taurocholate co-transporting polypeptide, NTCP. This is an important protein now within the field of research for the hepatitis B. It is not important clinically for now, but it can have really big importance soon. But not within the scope of this video. We will have attachment of the virus. After being attached, the envelope, which is made from bilipid layer, will kind of fuse with the bilipid layer of the hepatocyte, and we will have entry of the DNA and the capsid. Then, when we'll have nuclear import, we'll have relaxed circular DNA, which is the DNA of the hepatitis B. This DNA, which has some parts which are uncoiled and single strand, they will be like they will be complemented to get the cccDNA. This is covalently closed circular DNA. This kind of DNA is also important because in modern times and especially in research settings, this DNA, kind of DNA, is research within the patients for better diagnostics and classification. This DNA within the nucleus is then transcribed into multiple pre-genomic RNA. This RNA can go both ways. It can get translated into a capsid, or it can go from pre-genomic, take enzyme of polymerase, go inside the capsid, take nucleotide analogs from within the cells, and start the DNA synthesis. Then this kind of subunit of the virus in here can and infect our nucleus again to the subunit that has invaded within entry. Or it can take a kind of reticulum that has synthesized through translation a lot of the S antigens, merge with it, and then be secreted as new viruses that will go and infect other hepatocytes. So, to round it up again, the virus can go inside the cell, lose its envelope, then go inside the nucleus and lose its capsid. The DNA will go through transformation into a covalently closed circular DNA, cccDNA. Then this DNA will be the building block for pregenomic RNA. This RNA will be another building block for the envelope of the virus, the capsid of the virus, and the DNA of the virus. They can go into a new subunit of a capsid and DNA and reinfect the nucleus, or they can get an envelope and go out of the cell through secretion and infect other hepatocytes. And here we get an important part, which is the serology of the virus. It's important to understand that the DNA of the hepatitis B can be detected, and it's a really important diagnostic factor. The other antigens are the HBs antigen, the surface antigen, which is responsible for showing us that we are having the virus right now in our body. The E antigen, which is the HBe antigen, is responsible for the virulence. The presence of the E antigen within our blood shows that the virus is in active replication. And we have the core antigen. The core antigen cannot be detected easily within the blood. That's why it doesn't have specific diagnostic importance, although it has the same functional as with surface antigen. Then if we go to antibodies, we can have anti-surface antibodies, anti-E antibodies, which are called HBs antibodies, HBe antibodies, and respectively HBc antibodies. Each of these antibodies is secreted within different phases of our infection, which will be discussed later in the diagnostic serology section. So, to recap, the virus has a DNA, capsid, envelope, and E antigen and multiple enzymes. The ones that we can detect or have importance are the surface antigen, E antigen, core antigen, DNA, the surface antibody, E antibody, and C antibody, HBs antigen, HBe antigen, HBc antigen, HBs antibody, HBe antibody, HBc antibody. The epidemiology of hepatitis B starts by identifying the principal cause. It is, first of all, in high endemicity areas where we have a lot of hepatitis B patients. The main cause is perinatal infection. And in other places, second, correct this. In low endemicity areas, we will have sexual transmission that is predominant. This is usually in high income countries and low income countries. The transmission by blood or blood products or unsafe medical or surgical treatments or injection drug use is still a popular way within specific demographic groups. These groups are drug users, healthcare workers, and donor transplants, which is also through transfusion can be sometimes in countries or in areas where we don't have active screening of transplanted or transfused bloods or organs. The pathogenesis of hepatitis B can be classified into acute hepatitis B and chronic. During the acute phase, the main cellular target of the hepatitis B virus is hepatocytes. These hepatocytes will be infected by the virus, but the replication and the shedding of the virus within the cell are not cytotoxic or cytopathic. The cell isn't affected, but the cell will show specific proteins on the envelope, and a strong immune response will kill a large number of hepatocytes, releasing into the blood a lot of the internal enzymes of the liver, which will give us later increase in markers of liver, increase of bilirubin, and we will have decrease of the liver function because of the inflammation mantled by the immune response. This immune clearance of these cells will give us, in more than 99% of the time, in immunocompetent adults, resolution of the infection spontaneously. In the remaining 1%, or in the majority of the other infected people from other demographic groups, like people infected at birth, before the age of 10, and people who have deficiencies of adaptive immune response. These people are people with immune depression, people with autoimmune disease, on high immunosuppressive doses of drugs, people with genetic predisposition, these people will not have a cytotoxic T cell response. It will be weak, mono, or oligospecific, which will lead us into chronicization of the infection. This chronic phase will not happen when we have a robust T cell response that develops during an acute self-limited infection. This is for acute hepatitis. If we don't have this strong immune response, the patient will go into chronic hepatitis B. The pathogenesis of chronic hepatitis will be described in few phases. These phases were the building block of the old classification system. First of all, we should understand that chronic hepatitis B is a heterogeneous disease with variable levels of viral replication, liver inflammation, liver injury, and immune response. These changes depend on the phase, and the phases have a lot of factors that dictate when they start and when they finish. Usually, these phases are immune tolerant, immune elimination, and inactive infection. Immune tolerant is the phase where we will not have a adequate immune reaction, and it usually happens during childhood, and it can persist for years and decades if the patient was infected at birth or during early childhood. At this immune tolerant stage, the immune response tolerates the infection and does not cause liver inflammation or hepatocyte destruction. There is a lot of theories for why this happens, but mostly it's because the T cells don't recognize these surface antigens quickly enough, or they don't transmit the signal quickly enough to mount a good attack. This phase is characterized once again by non-inflammation of the liver, high replication, which means high HBe antigen, high levels of DNA in the blood. And since we don't have inflammation of hepatocytes, we don't have destruction of hepatocytes. The ALT and AST levels, which are enzymes present within the cells, the hepatocytes, are not elevated, and we will not have minimal inflammatory activity on liver biopsy. Liver biopsy used to be one of the gold standards for the diagnosis of liver damage. Nowadays, there are other methods that will be discussed later that are non-invasive, and also on these methods, we will see minimal inflammatory activity. When the immune tolerant phase finishes, we have an immune elimination phase. This phase is characterized by an active immune response. It causes necroinflammatory lesions and triggers hepatic fibrogenesis and progressive fibrosis. This happens when the hepatocytes are destroyed. We will have inflammatory reaction to destroy these cells and to control the damage after these cells. We will have deposition of different types of proteins to stop sometimes the internal damage, the microbleedings, the micro leakage. Mostly it's fibrin. Fibrin is one of the most important proteins that accumulate during inflammatory phases. This fibrogenesis and acute and progressive fibrosis is one of the hallmarks of chronic hepatitis. And since we have destruction of hepatocytes, a lot of enzymes cased within the cells like ALT and AST will be elevated. But since we have elimination of the infected cells and elimination of the virus, DNA levels can be lower normal, but will still be higher than normal, but can be lower than within immune tolerant, and will frequently fluctuate depending on the wave of the infection or the infectious process. So, within the immune activation or chronic hepatitis, we have two types. We have HBe positive, where we have a lot of HBe antigen. This is usually because the patient is infected with the wild type virus and are able to secrete HBe protein. And if the HBe antigen directly causes the seroconversion of HBe seroconversion into anti-HBe wild type virus. But sometimes you will have mutant virus that have no HBe. This is called HBe negative chronic hepatitis. Usually this type of hepatitis have really high ALT levels, more than 2000 in IU/ml. But this unit can be different within different books. But usually it is more than 3 times the normal of of the normal level. And since HBe positive form can have specific antibodies to tackle the virulence of the virus and the replication, the HBe negative form of chronic hepatitis is more severe than the HBe positive variation. So, these patients within the immune elimination phase can get the infection under control and go into inactive HBs carriage. This is because of successful immune elimination. This leads us into HBe seroconversion, HBs seroconversion, and HBC seroconversion. At the end of this successful immune elimination, we will have normal AST and ALT, normal HBV DNA, or undetectable. The normal is very low level, but the ideal is undetectable. Patients without cirrhosis will have normal liver histology, which on modern types of tests will give us only non-progressive liver fibrosis. And inactive HBs carriers can get reactivated when immunosuppressed. That's why we can understand that the HB hepatitis B serology is an important part of hepatitis B diagnostics. It is a helpful tool. It helps us understand where the virus is in the phase, prognostic values, and guide our treatment guidelines. The first thing we need to understand is the difference between HBe antigen positive infection and HBe negative infection. We have already talked about the old classification, and here we have the new classification with its specific differences in each serum antigen. But before going into that, it would be important to go into the basic interpretation of serological tests. And to understand this table, we need to understand what happens within stages of cured infection. When the person has the infection, which is at the exposure of 0 months, we can have a 4 weeks almost incubation period where the virus will start slowly replicating, and during this time we can start to detect HBs antigen and a little bit later HBe antigen. These two indicators indicate that we have the virus in our body, which is indicated by HBs antigen, and that it is replicating actively, which is indicated by HBe antigen. So within this period, the most important is HBs antigen. It can be found during the incubation period and within the serological period. Before that, 1 month can pass without any serological evidence. Then, the prodrome to the acute disease has really high elevated levels of HBs antigen, as we can see here. This prodrome and acute disease have high HBs antigen and high DNA because we have active replication of the virus and active destruction of hepatocytes. During that time, and within the activation of the cellular immune system, we will have activation of the non-cellular immune system, the humoral system. During that time, the first thing we can find is IgM anti-HBC. This anti-HBC will be an indicator that immunity has started to form. It is found especially in early convalescence phase. Then later, within 5 months or after 3 months of acute phase, anti-HBE will start to appear. This appearance of anti-HBE is really important because it shows us that the virus is under control. I just noticed that I have been saying anti. Maybe it's more correct to say anti. Anyway, they are both can be switched to each other. So, we have a specific period called the window period. This window period is the period between the disappearance of the HBs antigen and the seroconversion of it into anti-HBs antigen, the antibody. After this window version, the only detectable serological marker is the anti-HBC. All the other markers will be not visible. And this is important because a lot of the time, the really common to have misdiagnosis during this window period, which is usually between 5 and 6 months. But with the appearance of anti-HBE, anti-HBs, and anti-HBC during the late convalescence phase, we will have high anti-HBs and high anti-HBC. Anti-HBE will go down really fast. These are good indicators that the infection has gone through. Now that we understood when and how each one appears, we can start to analyze the serological test table. As we said, if we are having acute hepatitis B, we will have HBs antigen and HBe antigen. These two antigens show us that we are having the virus right now in our body. But it's still too early for the anti-HBs antigen to form within the acute phase. That's why we will find anti-HBC, more specifically the IgM anti-HBC. And since we are having acute replication of the virus within our body, we will find DNA. And since within the acute phase of the infection, we have destruction and inflammation of hepatocytes, we will have elevated liver markers like the ALTs and ASTs. So once again, in acute phase, we will have markers that show us that the virus is present and is replicating. These are HBV DNA, HBe antigen, and HBs antigen. If we would be able to detect the HBc antigen, we would find it also. But the HBc antigen is too weak and gets destroyed fast within our blood. Anti-HBc will be produced, and especially the IgM, since this is the only immune seroconversion that we can find within the acute phase. Then we can have the immune person. We have two types. We have person who is immune through infection or through vaccination. The thing to remember is, since the person is immune, he will not have markers. The person will not have HBs antigen, will not have HBe antigen, and will not have DNA. But since the infection have been or the vaccination have been for long time, the IgM anti-HBc will not be present. But if we take the infection, we will find that three of our antibodies are present: the anti-HBs, anti-HBe, and anti-HBc. The IgM version of the anti-HBc will not be present. And since we are not having inflammation, ALTs will be normal in both. Well, when we are having immunity through vaccination, we will only have anti-HBs. Anti-HBs is the only type of immunity acquired by antibodies after vaccination. So, to recap it, immunity through vaccination has anti-HBs only. Immunity through infection has anti-HBs, anti-HBc, and sometimes anti-HBe with no anti-HBs IgM variant. And we will not find any of the antigens for any of the infections. If the person didn't get immunity through infection or vaccination, this person is having chronic hepatitis B. During chronic hepatitis B, which we will later discuss in multiple phases, we will find that the virus is present within the body. That's why we will find DNA and HBs antigen. Then the variables are that ALT may be normal or elevated, depending if this is an active chronic infection or a dormant chronic infection. Same goes for HBe and anti-HBe, since the virus can be actively replicating or not, or since we can have the mutant type of HBe without HBe antigen, or we can have the normal. But the thing to remember that within chronic hepatitis, we will always have anti-HBc without the IgM since it's chronic. And we will always have the HBs antigen and the HBV DNA. To recap it, we will have markers of the virus itself, which are the DNA and the surface antigen. And we will have indications of an immune response that happened some time ago, which is the anti-HBc. HBe may or may not be present. The same goes for the markers of liver inflammation. Now, if we take the new classification of chronic hepatitis, we can see that, first of all, it can be classified into HBe negative and HBe positive. infection. Within the HBE positive infection, we can find the HBE DNA level is high and the ALT is low. The fibrosis is minimal and the markers of the presence of the virus are really high. And within the new classification, we have to differentiate between chronic infection and chronic hepatitis. In old books, chronic infection used to mean immune tolerant, and chronic hepatitis used to mean immune elimination phase. Now, this is the new nomenclature. This is the new classification type. Within chronic hepatitis, we will have fluctuating levels of DNA, which are lower than within chronic infection because we are having immune elimination. And the same goes for the ALT levels, which go up and down according to the inflammation of the liver. That's why we have hepatitis, we will have inflammation, and we will have high levels of ALT. The DNA and HBS will be a bit lower than within the previous phase, but we will have fibrosis and progressing fibrosis. So, this is the HBE antigen, which is a bit milder than the other type, which is HBE negative chronic infection. In HBE negative, the HBE DNA and the ALTs will both be low, and the virus will be well hidden within our cells. This mutant type of virus keeps a low immune profile. That's why we will have moderate or absent liver inflammation. And the degree of cirrhosis is moderate, but it will always be progressing. That's why what it makes it more dangerous than the other type. Since we cannot have B cell for HBE, we will not have an adequate reaction, an adequate immune reaction to the infection that's happening at this time. And when we will having hepatitis, which is a flare of the HBE negative infection, the fibrosis will be severe and we will have moderate inflammation, not high inflammation as in HBE positive. The high inflammation is here, even if in the chronic phase. Here, the immune reaction is high enough to cause fibrosis, but not high enough to give us virus elimination. And that's why when we are having this immune activation through the inflammation, we have flares of DNA and ALT at the same time. Functional cure is when we are having fibrosis that is not progressing. It is usually the same level that arrived in the other phases before it. The fibrosis stops and doesn't continue. The HBS antigen can be negative and the DNA is almost undetectable. This is lower than the lowest detectable DNA level, and the ALTs will come back to normal levels. And this is what we call a functional cure. This classification is important because it will help us later with our treatment, because people within chronic infection will need only antiviral treatment, but people within hepatitis flares might need hospitalization and will need extra treatment that is pathognomic, not etiological. And now about the clinic of hepatitis B. As we can see, the clinic is also divided into acute phase and chronic phase. During the acute phase, since we have inflammation and therefore destruction of hepatocytes, the main clinic will come because of this inflammation and because of the release of hepatic markers of inflammation and hepatic enzymes into the bloodstream and decrease of liver function within this duration of inflammation. So, the main clinic points are the elevation of ALTs and ASTs up to 1000 or 2000 units per liter. This can be different in other types of units, but it's mostly more than 5 to 10 times the normal level. ALT will be higher than AST, and the patient who recover, who don't go into chronic hepatitis, the normalization of ALTs and ASTs will be within 1 to 4 months. It can be a bit faster if the patient is receiving detoxification therapy. If the ALT is stably high for more than 6 months, this indicates that we have transmitted into the chronic phase. The clinic can be ecteric or non-ecteric. In ecteric, we will have jaundice as the main clinical symptom. In these patients, the bilirubin will be really high. In anecteric patients, the bilirubin may be normal, and this is another atypical variant of hepatitis, but it's quite common. The most common indicator of prognosis is prothrombin time. A high prothrombin time indicates that the liver is severely underworking and can be an indication of fulminant liver failure, which is one of the complications of hepatitis B. The markers of acute phase are IgM anti-HBC, HBs antigen, DNA, and anti-HBC, which is dominant by the IgM fraction. Later, at the end of the acute phase, we will have anti-HBe and anti-HBs getting seroconvert. We will have these antibodies. These antibodies indicate that we have good immune response. So the incubation period is within 1 to 4 months from exposure to the virus to the start of the symptoms. The symptoms usually are we cannot distinguish them from other hepatitis types. They are flu-like, fatigue, anorexia, nausea, vomiting, and right upper quadrant pain. This can be accompanied by jaundice, which is in almost all patients present, especially in the ecteric variant. We will have tender hepatomegaly, and the symptoms appear after 4 months of exposure and disappear around 1 month if the jaundice goes away and the fatigue. If not, this means that we are going into chronic phase. The chronic hepatitis B, as a definition, it's when we have hepatitis for more than 6 months. Usually, patients in the chronic period are either patients who have just transitioned or who have incidentally found the virus. This can be in two ways. A patient comes to the clinic, has full blood workout. In some countries, we have HBV screening annually, and the patient will find the hepatitis B. Or if we are in a country that doesn't have yearly or regular screening for hepatitis B, The patient will just have increase in ALT and AST, or the patient will be in a specific risk category. These patients will have incidental HBs antigen, which will prompt us to make a PCR to diagnose the DNA present in their blood. These risk categories are usually healthcare workers, injection drug users, and sex workers. Symptoms are also non-specific and they are wave-like. They come when we will have flares of chronic hepatitis B. The symptoms are fatigue, nausea, right upper quadrant tenderness, anorexia, myalgia, and arthralgias. Specific symptoms may arise if we have cirrhosis and we will have a cirrhotic syndrome, or we will have hepatocellular carcinoma syndromes. These two are complications of chronic hepatitis B. We will not go into them now since they need a full video on themselves, by themselves. Symptoms often do not correlate with the severity. Levels of serum aminotransminase also do not correlate with the severity. And hepatic liver injury also do not correlate. The physical exam may be normal, or the patient might have enlarged liver, unless the patient is having a flare, where we will have these symptoms and jaundice. When the patient is having jaundice or decompensated chronic hepatitis B, we will find splenomegaly, ascites, encephalopathy, and pedal edema. All of these are suggestive of cirrhosis and will indicate further test and evaluation. So the flares are usually due to changes in baseline hepatitis B virus replication or an immune response that have started again or due to repopulation of a new variant. These three variants will give us the flares. Usually, and more likely, it's the changes in baseline HBV replication. And this can be triggered by any life stress or physical stress. When we have high HBE antigen, this indicates that we are having a change in baseline replication. And when we have anti-HBE, this will mean that we are having control. These are important hallmarks of chronic hepatitis B. We will once again repeat the new nomenclature of the hepatitis, which is in phases and can be divided into first variant, which is hepatitis E, HBE antigen positive, and HBE antigen negative, and we will compare them to the old terminology. So the HBE positive chronic infection used to be termed as immune tolerant, as we said before. It is more frequent and prolonged in people who are infected prenatally, vertically from the mother, or with T cell function that is specific until young adulthood. These people will have immune tolerant phase. It is long and the spontaneous loss of HBE is really low. These patients are contagious because they have the highest level of DNA from all other patients, because the virus is actively replicating within these people. And since they are asymptomatic, if these people don't know that they are infected, they might be a great risk for epidemiological spreading of this virus. So, if we have HBE antigen positive hepatitis and not infection, this means that we have immune reaction, which is was termed immune elimination phase in the old nomenclature. After several years, and it happens from the immune tolerant. And in patients who are infected within adulthood, it can come really fast, within months. We have multiple outcomes. Some people can achieve seroconversion and the HBV DNA will be suppressed and the patient will go into an HBe negative infection phase and will become an asymptomatic carrier with controlled and functional suppression of the virus. And other people will go into HBe negative, will fail to go into HBe negative phase. And these patients will have a lot of hepatitis flares and usually end up with really big liver damage and a lot of complications. You can see it again in the table. That will explain almost everything we need to know. The phase 3 is the HBe negative chronic infection, which is inactive carrier phase. This is the phase that these two phases must go into. These people have low risk of progression to cirrhosis and hepatocellular carcinoma. And they can stay in it for a long time if they keep taking the antiviral drugs long term. And usually it's lifelong. This These patients will lose the HBe antigen, but will still have the HBs antigen. Some people might lose it and have seroconversion, which is spontaneous. And these people will have really undetectable doses of HBs antigen and not an actual loss. And this is the most satisfactory phase that we can go into with our patients. Patients who are HBe negative chronic in the phase of HBe negative chronic hepatitis are patients who are having the virus with a mutation or a wild type. And these patients have the worst prognosis. This is because the liver is having extensive fibrosis and necroinflammation. And since they have this mutant virus, the HBe antigen expression is different than in other viruses, and the body cannot produce anti-HBe to the mutated HBe antigen. That's why we call it HBe antigen negative, because we also cannot detect this mutant variant. The body will not have antibodies that will control the replication of the virus. The virus will replicate really fast, and we will have low rates of spontaneous disease remission. This is the worst case scenario for our patients. And another phase that is a really rare phase, but we can still see it, is when the patient has occult HBV infection. There is big controversy around this phase, since a lot of researchers don't think that this phase actually exists, because they think that a patient which the serum is negative for HBs antigen means that it's in there, but we cannot detect it. But other people think that the virus have been resolved. There is big controversy around this, and we will not go into it now. Only we need to know that the patient might and might not have HBs antigen, might and might not have anti-HBs antibodies, and they will have negative HBs antigen. The patient in this phase will have anti-HBC only, which is kind of weird by itself since the patient has already got the infection. And this usually happens after long-term taking of the antiviral drugs. Now we will see it again in our table. The thing we need to make sure about are the HBS antigen, HBe antigen, HBV DNA, ALTs, and the liver inflammation. As we can see in these new tables, we don't have liver biopsy anymore because liver disease can be now detected using ultrasound. If we take each of the two phases, we can also put them into infection hepatitis, infection hepatitis. The infection part will have normal ALTs. The hepatitis part will have high ALTs and ASTs because we are having inflammation and destruction of the cells and release of these markers. In all the phases, we will have HBe antigen if we have positive. In the other that are negative, we will have both as negative. In HBe antigen, the HBs antigen is usually high in both because here in the chronic HBV infection, the virus is continuing to replicate as we saw. That's why the DNA is quite high. In chronic hepatitis, the DNA will still be high, but it will be lower than within the infection phase because now we are having inflammation that is trying to control. Here it's what used to call immune tolerant, and here it's immune reactive. We are having a reaction, an inflammatory reaction in the liver, which will lead to high ALTs and will lead to decrease in HB antigen, DNA, and HBs antigen. These slow, gradual decreases within the chronic hepatitis phase indicate that the patient is getting better. Although clinically, the patient in chronic hepatitis will feel a lot worse. After phase 2, the patient can go into phase 3 or stay within phase 2. If the patient goes into phase 3, this is the ideal for us. The immune response has been good enough that the DNA now is in our goal. This is our goal to get into less than 2000 units per milliliter. The HBe negative HBe antigen is negative because we have immune control over the replication. And the HBs antigen is low because a lot of the virus that was in infected hepatocytes has been already controlled and eliminated. It is low because we will always have residual DNA inside our other hepatocytes. But since it's not replicating, it is under control. Liver disease and inflammation will be none because we don't have replication that gives us inflammation. That's why the inflammation will go away and the fibrosis that has already been formed within these stages will not progress. In the old terminology, this used to be called inactive carrier. In the new terminology, it's called chronic HBe antigen negative hepatitis B virus infection. The phase 4, as we said, is usually because of a mutant phase, mutant type of virus. We will have intermediate HBs antigen. We will have negative HBe because we have a mutant type of HBe. Our DNA will be bigger than the goal, but in, in spite of having intermediate lab results in these areas, the ALTs will be quite elevated and the inflammation will be really severe. This is the worst prognostic phase that we can go into. The phase 5 is really rare for our patients, but it can come where the patient will not have DNA anymore, which is lower than the detected threshold. HbE will be negative, HbS will be negative, ALT will be normal, we'll have no inflammation. The only thing that we can find is anti-HBC. And to try to differentiate occult or resolved infection from vaccination. In vaccination, we have anti-HBS antibody, but in occult, we'll have only anti-HBC. And this is usually rare to find in patients. After that, we have to start with our practical part. It's the initial assessment. Any patient who comes with a risk group of hepatitis B or with an already made diagnosis of hepatitis B, and if the patient has been exposed to hepatitis B, what we need to do, first of all, the patient must go through a hepatitis B marker course. This includes serology for hepatitis E antigen and anti-hepatitis E, hepatitis S antigen, and HBV DNA. These are the first ones we need to do. The hepatitis E antigen will show us which phase it is in. The anti-HBE will show us if it's beginning to seroconvert or not. The HBS antigen will show us if we have the virus, and the HBV DNA through PCR will confirm this. We can add HBC and anti-HBC IgM as extra. Biochemical analysis should have ALTs and ASTs, bilirubin to check for liver function and inflammation, GGT and alkaline phosphatase for the same reason, and albumin should be checked to exclude any kind of pancreatic involvement. Coagulogram is needed to check for prothrombin time, and this is important for prognosis. And of course, general blood analysis. The general blood analysis will show us if we have any extra component to our illness. Then the patient should be checked by echography to check the hepatomegaly, the splenomegaly, and sometimes to check for complication of cirrhosis. For example, look for ascites, look for any kind of new formations in the liver indicative of hepatocellular carcinoma, and to check for any kind of portal hypertension. And elastometry should be done. Elastometry is a new way of trying to assess the type of tissues we have inside the liver through echography. This is non-invasive and it has replaced liver biopsy. Within elastometry, we can see the fibrosis of the patient. We can check if the patient has went into cirrhosis, and it's important to know which later stage we will go into. And of course, we will check for comorbidities, especially for people with risk like HIV, HCV, and HDV. This should be done for all our patients. Here in this table, we can find the same. Selected cases might have liver biopsy, but in our current modern world, this is highly doubtable. And it have been replaced by elastometry since the patients that we have usually have bleeding problems because of liver not being able to produce enough fibrinogen. And that's why, to decrease the risk of the patient uncontrollable bleeding and having internal bleeding and surgical intervention, we will use elastometry. It is non-invasive. And all of we are talking about fibrosis will be in another video by itself about liver function, how to assess liver function, what are the complications, and symptomatic treatment of all these liver kind of disturbances. After we have made the initial assessment, we can go into therapy. The goals of our therapy are the induction of long-term suppression of HBV DNA levels. It is to get our patient into an inactive carrier, which is an HBe negative chronic infection. The induction of HBe antigen loss, with or without anti-HBe seroconversion. Some patient will not go into HBe seroconversion, but will have HBe antigen loss when on long-term drugs. And this can be part of a partial immune control of the chronic infection if we have HBe loss without the anti-HBe seroconversion, ALT normalization, and HBs loss. But as we say, this is a functional cure and this is really rare. Usually our endpoint is long-term suppression of HBV DNA. The HBs loss is also an endpoint, but with HBs seroconversion. So the indication to start our treatment, they are the same for HBe negative and HBe positive patients. Any patient with HBs antigen positive should go through these criteria. The first criteria is the serum HBV DNA level, the ALT level, and the severity of the disease. Here in the table, we will have an explanation. If the patient is HBs antigen positive and has cirrhosis, we go into therapy. If the patient has cirrhosis but no um, if I'm sorry, if the patient is having HBs positive and cirrhosis, we go to therapy. If the patient has SBS antigen with no cirrhosis, we check the DNA level. If the DNA level is more than 2000, we go into therapy. If the HBV DNA is not more than 2000, then we check the ALT. If the ALT is elevated, we go into therapy. If it's normal, we don't go. So if our patient has HBs antigen positive and doesn't have cirrhosis, doesn't have high HBV DNA levels, doesn't have ALT increase, we don't go into therapy and we wait. But if the patient has any of the following, we will start. Elevated ALT, we start the therapy. High HBV DNA, without without looking even at ALT levels, we can start therapy. And if the patient is having cirrhosis and HBS positive antigen, we started without looking at other markers. Here is another guideline. This one is more simple. This one has even follow-ups. We check the patient that is suspected. If the HBS is negative and anti-HBC is positive, we will not have any other interventions other than regularly checking the patient. And in case of immunocompromised patients, we can start prophylaxis, but this is a specific type of patient. If the patient is positive with no signs of hepatitis, then we will just monitor the patient. If the patient goes into hepatitis, not infection, this means that the patient needs to start therapy. This is an increased ALTs. If the patient is at risk of any other complications, we start our therapy. This is a specific type of contingent of people. Here we have the same that's in the pictures but written. Now the agents of our treatment. Nowadays, the treatment used is nucleotide agonists. Here we have them. Later, we will have specific tables which will show us the difference of treatment effectiveness and the difference of relapse within these classes. The classes used nowadays are nucleoside analogs and more commonly nucleotide analogs. These are the golden standard for treatment right now. Earlier, we used to use interferons, especially the interferon alpha 2A and interferon alpha 2B. These are pegylated interferon. They had a lot of side effects, but during the older days, these were quite effective. The viruses have since worked out really good resistance against them. That's why we have these low numbers here of normalization and suppression. But if we check for others, the suppression can be really higher. Here we see within normal doses, it is almost 94% for tenofovir. Now back into them to talk a little bit about them. These types of drugs can be classified into two parts: low barrier against resistance and high barrier against resistance. If our patient is already on low barrier resistance drugs and is not having failure, the patient should continue taking them. But if our patient starts having resistance or starts having failure of his drug regimen, then we should always switch him to high barrier to resistance drugs. These drugs are lamivudine, adifovir, and telbivudine. Usually on the packages and in scientific papers, we will see them as LAM, ADV, and TBV. The high barrier to resistance drugs are entecavir, tenofovir, which has two variants, the disoproxil and the alafenamide. These two types of tenofovir are now the golden standard because they are the same one used for HIV. And since we have a lot of patients with double infection of HIV and HBV, tenofovir has become one of the most popular drugs used for treatment. So the treatment of choice is long-term administration of a potent NA with high barrier of resistance. This is regardless of the severity of the liver disease. The preferred ones are entecavir and tenofovir with its both variants. Later we will see the difference between variant number 1 and variant number 2. Nowadays, the low barrier drugs are not used or not recommended, but they can still be used if the patient has been using these drugs for a long time, especially if our patient has been having hepatitis for the last few years. Here we have a table, an interesting table showing us the incidence of resistance of each of the drugs on a 5-year period. People who had been using lamivudine, 70% of them after 5 years develop resistance. And as you can see, the high barrier drugs, less than 1.2% of these patients developed resistance after 5 years of entecavir, and almost 0% have been with tenofovir in its both variants. A question has been discussed lately is when to discontinue the treatment. Some patients may stop the treatment if they are HBe antigen positive with seroconversion and we have HBV DNA undetectable for more than a year. If the patient has two tests of PCR of HBV DNA with 1 year apart and hasn't had any flares within this year, this patient may stop his NAs. And if the patient has HBs antigen elimination, only these two patients can stop our treatment. And some doctors don't recommend them to stop their treatment. Some patients might continue their treatment even if they have the criteria for discontinuation. But this becomes more of a subjective choice of the treating doctor. In terms of our therapy, we can check two measures. The first measure is viral and the second is biochemical. Within the viral, we have viral response. Viral response or virological response is usually by checking the PCR. The PCR should show undetectable HBV DNA. This is when we have adequate viral response to our therapy. We can have primary non-response is when we have less than 1 logotype tenth decrease in the serum HBV DNA after 3 months of therapy, which should be almost around 10 times less than usual, which is at least a 50 to 10% decrease. Partial virological response is when we have a decrease of HBV DNA more than 1 logotype of 10 units per milliliter, but it's still detectable after 12 months of therapy in compliant patients. Virological breakthrough is a confirmed DNA increase level more than 1 logotype 10 compared to the nadir, which is the lowest value of DNA level while on therapy. In patients who discontinue nucleotide analogs, sustained off-therapeutic virological response should be defined as an HBV DNA level of less than 2000 units per milliliter for at least 12 months after the end of the therapy. This is how we can check and maintain the efficacy of our treatment and drugs, and to check for the fact that our drug are actually working on this virus and this virus is not resistant to the class of drugs we are using. Biochemical response is when we have normalization of ALT levels. Usually, it should occur within 1 to 4 months after we have viral suppression, and we should do it every 3 months. We should check it for every 3 months within a year post-treatment. When we have biochemical suppression of ALT levels until normal or normalization of ALT levels, this means that the therapy outcome is normal. How do we manage a virological failure? We should first of all check for NA compliance. This compliance should be checked by asking the patient, and there is a lot of scales and psychological tests that we can ask the patient to answer, which can give us a score that predicts the probability of this patient actually being on the drug or not. These can be found on the site for HIV management, and they are the same for HBV treatment. Now, when we have treatment failure, we should change the drug used, which is usually a low barrier to resistance drug, into a high barrier. And if the resistance is to a low barrier drug, we should not give another low barrier drug. We should always go up. That's why we change to an NA with a higher resistance barrier. And if the patient does not have good treatment or is late to the treatment or is not taking the treatment, the hepatitis can progress really fast and it can go into hepatocellular carcinoma, cirrhosis, and the risk factors. First of all, the complications will be in a video by itself in the hepatic disturbances and hepatic pathologies. The risk factors for developing hepatocellular carcinoma or progression to cirrhosis can be related to the host, which if the patient has chronic necroinflammation, is older, is male, has alcoholic abuse, or has co-infections with HIV, other hepatitis viruses, diabetes, metabolic syndromes, is an active smoker, or if the family has a history, which is here the biggest point. The biggest points of risk are positive family history, co-infection, and alcohol abuse. And another risk factor for hepatocellular carcinoma of HBV is if the HBV DNA or HBS levels are really high and the genotype is C or B. Usually, the C is more dangerous, which are kinds of specific mutations. Um, then we have cirrhosis, and especially decompensated cirrhosis. In patients with decompensated cirrhosis, we directly start our NA. It doesn't matter if the patient is treatment naive or treatment experienced, we always start NA with high barrier to resistance. And we have to assess him for liver transplantation because cirrhosis is an end-stage disease of the liver. The patient will not have origination of the liver. And they should be closely monitored because any drug that is given to these patients will accumulate in the bloodstream and can give us rare side effects. It can lead to lactic acidosis. It can lead a lot of life-threatening complications like gastric bleeding, like varicose veins, portal hypertension, ascites with secondary infections, and kidney dysfunctions. That's why cirrhosis is a really big theme and should not be taken lightly. The main thing to understand is when the patient gets into cirrhosis, we should start the treatment, and the diagnosis of cirrhosis is now made using echography and especially elastometry. Special populations that have hepatitis B. First of all, it's the co-infection with HIV. All HIV positive patients with HBV co-infection should start immediately antiretroviral therapy, irrespective of their CD4 count. And their antiretroviral therapy should contain tenofovir. This drug has double action on HIV and hepatitis B. In HBV plus HCV patients, direct acting antivirals like ribavirin may cause reactivation of hepatitis B since the direct acting antivirals will produce liver inflammation and hepatocyte destruction, and it will give us an increased release of hepatitis B virus. So patients who already fulfill the criteria for HBV treatment should receive HBV treatment. If the patient is HBs antigen positive and has already is on DAA therapy, the patient should start NA prophylaxis at the same time with DAA, or until like we started at the same time and we finish the NAs 12 weeks after discontinuing the ribavirin or the other direct antiviral agents, and should be monitored closely. This is used to have prophylaxis against the first point, where if we start taking DAAs and we have reactivation of HBV, this way we have DAAs and NAs, and we are covering both of these infections. If the patient is HBs negative and has anti-HBC positive, the patient should only be monitored and tested for reactivation if the ALT is elevated, but usually ALT is elevated when taking DAAs. Another important group of people are the patients with acute hepatitis B. The main goal of this phase is to prevent liver failure, which can be acute or subacute or fulminant. So these patients, usually 95% of these adults, do not require HBV treatment and do not require any specific treatment. Most of the treatment is symptomatic and disintoxication. How we check if this patient has severe acute hepatitis B? This if the patient is having coagulopathy with INR different or prothrombin course different. If the jaundice is more than 4 weeks, these patients should be treated with NA because this acute hepatitis can go into liver failure and can go into chronic phase really quick. Healthcare workers should always take the hepatitis B vaccine and have regular reminders of this vaccine. And if they are treating any patient with an HBV DNA more than 200 and they have any exposure prone procedure like extensive surgery, or if it's a nurse that works in the manipulation department where she will put a lot of catheters, she will have IV injections, she will give IV injections to the patient. These people may be treated with prophylactic doses of NA to reduce transmission risk, but there is no strong recommendations. The recommendation is weak and it depends on multiple different research papers. So this point should be taken with more research later. Usually, vaccination and procedures should be more than enough. Pregnancy. All pregnant women should be screened for HBs antigen in the first trimester of pregnancy, and this is a high recommendation. All pregnant women with any kind of fibrosis or cirrhosis or uh, any kind of liver disease and have chronic hepatitis B should be treated with TDF. This is the TDF variant of the tenofovir. This is important because TDF has less effect on other organs and less side effects. If we have high DNA level of more than 200,000 units, or the HBS level is 4 logotype 10 of a unit, antiviral prophylaxis should start at week 24 to 28 of gestation and continue for up to 12 weeks after delivery. This is important to prevent vertical risk of transmission. Now, lastly, we will have extra information about multiple ideas that we have already went through. This is the main studies for treatment of HBe antigen positive chronic hepatitis for people with pegylated interferon alpha and other therapy. We can see here that the dose used, how many percent of patient had seroconversion, how many percent had DNA that is less than 60 to 80, which is usually the threshold for detection. How many of them had ALT normalization, and how many of them had loss of HBS. As we see, the loss of HBS is quite small in all of them, but it's mostly with pegylated. But this does not recommend pegylated anymore because they have really high side effects. The patient don't tolerate them well. And we have low seroconversion rate in comparison to others, especially if we see DNA levels. Here we have low percent of viral control. as if in the new generations we can see up to 76%. ALT normalization here is for one third to one half. Here it's almost three-thirds of patient, especially with tenofovir. That's why in the new recommendations for HBE positive chronic hepatitis, we see that patients are having tenofovir as the best option. So the results of HBE negative chronic hepatitis show that the DNA elimination is almost the best in tenofovir, which is almost 93-94%. ALT normalization is 83 to 76%. And HBS loss is only with pegylated interferon. But as we can see, this shows that the failure of our drugs after 52 weeks of therapy is really low in compared to the old generation of interferons. The new NA drugs have really high, which can go to up to 80% of elimination of DNA and 80% of ALT normalization. We can go back to our older table, which show us the resistance for lamivudine and other drugs, and we see that tenofovir is the best. Another thing to check is the indication to select ETV or TAF over TDF. So, if the patient is over 60%, 60 years old, and if it has bone disease or renal alterations, usually TAF is selected. TAF has no dose adjustment for adults and adolescents. If the creatinine is more than the clearance is less than 15. And that's what we need to remember about TAF and TDF. This is important because they have really big side effects on liver, and we need to try and have adequate doses inside our blood. In chronic liver disease assessment, this is cirrhosis assessment. As we said that in fibrosis we have 4 stages. These 4 stages are dependent on our ultrasound results. That can be 1, which is no fibrosis, 2 with minimal, 3 with moderate, and 4 it's almost cirrhosis. Then when we get to cirrhosis, we have chronic liver disease assessment, which is the Child-Pugh score. The Child-Pugh score is used as a prognostic value. This prognostic value is important for our patient with cirrhosis to know when to start more heavy monitoring. So we have to make the score by checking each of these parameters: albumin, ascites, bilirubin, encephalopathy, seconds over control, this is for PPT, and INR. After checking all of this in the coagulogram, biochemical blood analysis, and patient history taking or physical exam, we can calculate how many score he got, and if the patient has from 5 to 6, and it's class A. This is well-compensated liver disease, and the patient has high 2-year survival rate. If the patient has C class, which is fully decompensated disease, the patient has almost 45% survival rate. And encephalopathy needs to be graded alone with its own scale. The encephalopathy score is usually with none, and grade 1 to 2 are patients that are still able to contact and has moderate to mild memory impairment, attention impairment. At third to fourth scale of encephalopathy, the patient has severe problems that can limit his communication and daily life. So, once again, we have to look for the Child-Pugh score in every patient. We have to check in biochemical analysis the GFR, the albumin for renal function, to know when to use TAF over TDF, because TAF is well tolerated and doesn't affect the kidneys. And we have to always try to get our patients entecavir, tenofovir, and other type of tenofovir. And this is all we need to know about hepatitis B as a virus and as a disease itself. And as for the complications of hepatitis B, this will be a video by itself to talk about liver decompensation, liver disturbances, encephalopathy, portal hypertension, and everything we need to know. This mind map was made using the X mind map. The mind map is available in our link in the description. And write in the comments which other disease you would like to be on the next video. Thank you for being in this video with us. Hopefully that this video will be helpful for you in your next patients. And as we have said, we are not here to prepare for exams. We are here to treat our patients. See you in the next video.